You said it's important to examine whether interventions are being delivered in a high quality way, and I think that's kind of a wonderful platitude, and I think we'd all go, oh yeah, that sounds great. But in the context of things changing and of the better way being in part fit to the context and in part fidelity to the theory and mechanism of action, I find it very difficult to wrap my mind around what it means to look at whether an intervention is being delivered in a high quality way. If you could address that.
Yeah, so it's a wonderful question, and I think it's funny. There are a lot of very challenging questions that come up, and I hate to say it, but another platitude often comes to mind, not only for myself, but I can think of several others, where it depends, right? A lot of it depends on what you know about your intervention, what you're actually looking for, and what you're potentially able to derive. So I do think so some people, Abe Wandersman comes to mind, who focuses on the prevention side of things, with this idea of are outcomes getting better as the ultimate sense of whether you're delivering high quality care. Are outcomes getting better, and are you sensitive to what the actual needs of the client who's coming in are, and how well can that be measured over time? That's one. The second thing actually is to open that up. As people are now starting to think about their interventions as different potential components with different adaptations that can occur, they're gathering more of that data to then be able to look across a whole panel of people who are receiving the intervention and get, for the specific intervention, a much better view of what seems to be contributing to the highest quality responses. So I think it is a moving space. I think there are there are different degrees of evidence where one can say, okay, we have a good sense because we've actually looked at variation of delivering that care to look at what factors have already been associated with high quality versus low quality. I think in other cases, it's actually an opportunity to drive better measurement. And we in mental health are struggling with this a lot because on the psychotherapy end, there's very few quality measures that are being implemented and being used. And we know that the way that care is being structured as it's evolving over time, quality metrics are going to determine whether reimbursement is going to occur and even whether types of interventions can be offered. And so in that case, there's a tremendous amount of people doing a lot of things under this broad heading of psychotherapy. And I think there's a case where we need to do a much better job systematically. And a few of our investigators are trying to do this, where you're identifying what pieces of the intervention relate to higher quality and what seem not to. So there's a longer discussion there, but that's just a couple, hopefully on point thoughts.
Oh, thank you very much for your insights. The question that came to me was in your dynamism and your sustainability, to what extent is kind of the magnitude of the problem in the patient's life a contributor to that? In other words, I can imagine somebody that in the mental health arena, maybe their family has an event where there's an addiction or maybe a suicide attempt or something like that, versus something that maybe isn't quite as salient, and to what extent that impacts your model.
Yeah, I think that's absolutely. I think that's right on from where we're thinking. There are a few people who are trying, especially since historically, we have a lot of work that we support in primary care. And the traditional way to study primary care depression, which is what's been mostly studied in primary care, was to assume that there were no other problems going on, right? And so you found the population, the very rare population that was only struggling with this one problem, and then you delivered your intervention, and then you said, hey, it looks like we can make a good difference. And then, of course, came that implementation challenge, where all of a sudden, the average patient in my clinic has 5 or more chronic conditions that we're trying to deal with. And it's absolutely right that as we're thinking about these different levels and the fit, it's not just fit within a setting, but it's how actually you're accommodating with patient preferences, even what someone is struggling with on that given day. We've dealt with this a lot in terms of certain psychotherapies as being tested, where they're very nicely modularized. The problem is that the person who comes in may not want to talk about whatever the topic is for Module 3. They want to jump to Module 7. And actually, the more successful effectiveness studies, I would say, have been able to allow for that kind of choice and that kind of preference. So I think it's absolutely crucial, and I think it's another one that ultimately will push us in a much better place than assuming that someone is here for what I want them to deal with. And so I think it's absolutely right, and I think it's a key component that's often missed, in the same way that we think often, for the purposes of research, that all of our clients look exactly the same and they're all coming in waiting for what we're ready to implement. So I think it's a great point.
Hi, I wanted to tie my leg to the chair and not say anything. No, my name is Lori Ramig. I'm from Colorado and New York City, and I've done years of randomized control trials with patients with Parkinson's disease for voice treatment. So as you may know, the word adaptation strikes terror into the heart of the principal investigator on such trials, who has attempted to document efficacy and evidence in an area where there has never been evidence before. On the other hand, we want to scale up our interventions so that they are implemented, so we get your issue of adaptation, and we have certainly tried to put on many pairs of glasses over the years to do that. But help us a bit, because we can't run a study on every variation of a treatment to see how it maintains evidence, but we want to be implemented in environments. And so in my talk this afternoon, you'll get to see what we did, but you are an expert, so it would help us to not be traumatized by adaptation so we can implement better.
So
Thank
the
you.
goal, I think, is certainly not to provide terror. So sorry. And hopefully the appetite will remain. I was not trying to destroy anyone's lunch either.
Yes, yes.
But here's one of the things that I think, at least, and again, I mean, I'm going to know far more about what's going on in the mental health space than in some of the other spaces. So apologies if this doesn't fit as well within any one specific content area. But I think what we have had are more folks who are saying, okay, in the past we were looking at our intervention as a package, as this whole package, and everyone was going to get the package, and then we were going to see what was the outcome of having received that package. I do think in the mental health space there has been more thinking about how do we understand a couple of things, one of which is the potential differential impact of individual components of that intervention, and the way to be able to, ideally over time, and maybe differential among the population within a given trial, but adding that information that allows for much more understanding of what would, if one thinks these are the core components, what is the evidence behind that, and how then does that give us more to go on as we're thinking about bringing the intervention further. I do think that at least on our end in mental health has been something that only recently has been more embraced. Before it was the science of groups, of course, where it's, if this package did better than that, unfortunately, on the mental health side, that was what was just assumed. You just got to do the package. So I think that's one key area where I think we can do a lot better. So it's not necessarily that that we're having to change entirely to throw out the good evidence that has been generated. But what's the additional context that we can provide? And there are actually some reporting efforts in terms of Consort and others to say the more that we're able to report in terms of the design or the Précis criteria, as we're looking at how pragmatic or explanatory a given trial is, that's going to give us more understanding to carry further. So that I think is one. There was another thing that was coming to mind, and I think calories will help. Oh, sorry. So Larry.
Thank you.
I think part of your question was focused on the issue of the trialist who strives for fidelity in the implementation in the trial. I don't think anything we're arguing here is against that. Clearly, you can't have practitioners going off in all different directions when you're specifically doing an efficacy trial. So we're talking mainly about what happens after you have that initial evidence and you're taking it to scale or taking it to other settings and populations. Your second point, as I understood your primary concern, is you can't do randomized controlled trials in all those settings with all the variations. And I don't think we're arguing that either. I think we're saying that evaluation of programs as you adapt them is the ongoing mechanism for studying ways in which adaptation work in different settings.
I actually was addressing, once you've done the randomized control trial and you want to scale up to the real world, how do you ensure the fidelity of the treatment as much as possible? And clearly, if you move from efficacy to effectiveness, you're going to get some variation on the theme over time. And so that's my worry about adaptation, because we've tried very hard to help our clinicians understand it's really important that you embrace these core elements of this protocol in order to get this effect in the real clinical world. So we've tried to stifle adaptation, whereas I understand the reason for it, but just the idea is the balance, because you don't want to diminish treatment outcomes ever, period. You don't want to.
Right. No, and I think what you said right there in terms of core elements, I think within, we have a couple of different approaches where people are trying to, and based on a lot of prior intervention research, are trying to distill across different types of interventions. There's a common factors approach and a common elements approach. In both cases, trying to identify in a much more systematic way what should really be held. I think one of the challenges that we on the scientific end have not done as much as ideally we would have liked to be able to inform that next step. So the better that we can, the better that over time we're able to understand a bit more about the how and why things work. It's also where NIMH has been actually trying to revamp a lot of the clinical trials that it does, so that every trial that doesn't show a benefit, that there's much more of an understanding of why that didn't happen. And there's much more, Larry talked about moderators and mediators, and of course that's certainly one step. It's easier for some on the experimental therapeutic side to say there's a receptor in the brain that we're trying to hit. If we don't hit that, we're unsuccessful. But at least the broader thought about understanding what you're targeting, and is that target underneath the overall outcome being engaged, and can we improve from it? So I think the fact that you're focusing on these core elements is actually a step ahead of where some of the folks have been, where they've just said, we like our package.
Right. And I think also doing comparative treatments where you change one element and look at the long-term outcome. You really do understand the basic mechanism of your treatment.
Exactly.
Thank you.
Yeah, no, that's right.
And also, you referred to adaptive design. So the Hendricks Brown and colleagues 2009 in Annual Review of Public Health, there's an article on adaptive designs where you can take into account some of these variations in a systematic way so it's controlled.
Howard Goldstein from University of South Florida. One of the things I think we're struggling with as an audience is when and how implementation research gets infused into the process. And I think it's good to have some illustrations of the development of clinical interventions and the role of implementation research early on in the process, later on in the process. And I was wondering if, Dr. Ahrens, you might talk about the development of SafeCare and how that kind of came about.
Okay, well, that's two questions, but SafeCare is not mine. Developed by John Lutzker, I think originally about over 30 years ago from a SAMHSA service grant. And it developed into, originally it was called Project 12 Ways, which had 12 components. SafeCare currently has 3 components, just distilled down to focus on child neglect. But the implementation research didn't come into the picture until, about 8 or 9 years ago, as kind of a function of my interest in my meeting Mark Chaffin and Kathy Sims from Oklahoma. And even then, it was SafeCare as implemented in Oklahoma, so it wasn't exactly the SafeCare that John Lutzker and his developing National SafeCare Training and Research Center were focusing in. Now, with my sustainment study, which is in 2 states and 87 counties across Oklahoma and California, what we're seeing is variation in the program itself and the way it's delivered in different sites. So we'll be able to learn something about that. And one of the issues we're struggling with is, so what really is fidelity to the model? Because the Oklahoma system conceptualizes fidelity a little bit different than the SafeCare intervention developers, and so that is a bit of a moving target. But in terms of kind of where does implementation science come in, I think there have been calls for really involving intervention developers early in thinking about implementation. So designing with implementability and sustainment in mind from the get-go. And I think if it's filtered into the research program around intervention development and testing, then you could be addressing the implementation issues and make it, make the intervention fit better with whatever particular service system you're considering.
I'll add a few thoughts. I think that's a really important question, first of all, to help you get a sense of what implementation research can look like, but also to accelerate the move into implementation research, either simultaneous to conducting treatment development, treatment effectiveness testing, or initial efforts to scale up or train. There have been many instances in our field of mental health and child welfare and social services where the question is starting with something that is being tested in an effectiveness setting for the first time. So I might just get a sense, how many of you are doing something like that? You're doing some effectiveness research on a treatment or program. Okay. Are the rest of you doing efficacy research, basic testing of something in a really controlled setting? Okay, a few. Okay. Well, as you begin to test a program or a treatment, I think early on, and we mentioned yesterday, there's one paper out about designing for dissemination. My colleague Ross Brownson wrote it, but that was really on the dissemination of information, and several of us are chomping at the bit to apply this concept to implementation. How do we design interventions for implementation, and what kind of thinking has to happen very early on in the development and testing of an intervention? And I think, I haven't written this, I don't know anybody who has, but somebody, you all ought to write it. So, one of the questions is, what kind of training is required? And almost every treatment or program developer is doing or designing some kind of training. So that can be examined and detailed, documented. This is kind of an observational or a characterization of the components, the delivery system that Matt Kruder talked about yesterday. So training is a really important part of that. Who trains, where, how much, detailing all of that will give a window into what are going to be the challenges of moving from one setting or from one scale to another. I think another set of questions has to do with some of the early implementation outcomes. How acceptable is this? And our field comes from a whole set of questions from the diffusion of innovation from Rogers. Can we see the comparative advantage of this? If not, how can we articulate that so that we say this particular intervention has some value added? I think unless that is clear, people are not going to adopt it. It's not going to get implemented. Issues of acceptability and appropriateness. I recalled in Larry's example of bundling the flu shot and the fecal blood testing studies. Matt Kruder was leading a study at our shop about 211 calls. Does anybody do you come from states where there's a 211 system? It's like 911, but in Missouri we have a statewide system, so people who need services can pick up the phone and call 211. So Matt was proposing implementing referrals to smoking quit lines in the 211 system. And I was at the table, and it had the obvious advantage of reach that Larry emphasized, but I raised the question of how will this be perceived as appropriate? Because 80% of the calls are for utilities assistance. or food assistance. So we have a whole workforce who's picking up the phone. They're used to talking to people about here's where to get help with your utilities, here's a source of supplemental food. What do they think about saying, and by the way, are you a smoker? And would you like to be referred to a quit line? You know, and frankly, I thought this is an evidence-based intervention, but I had red flags about the acceptability. Similarly, our depression care in aging services. You know, they were arranging assistance for functional assistance. How would they feel about intervening in depression? Well, my fears were not founded because both the call workers and the callers were quite receptive to a referral to a smoking quit line. So these questions of, is it acceptable, is it appropriate, what infrastructure is required, do we have a place to record the data? These are some of the ways that I think you can take initial steps into implementation while effectiveness studies are being conducted. And I think gathering some of this data and the broader thinking that's required around this will accelerate implementation and delay this very long, protracted, what we call the pipeline of how long it takes before something is evidence tested before it's widely used. We got to be thinking about paving the way and what will it take to deliver this. So I hope that's helpful in thinking about how to get started with implementation research.
Yeah, I'm Mark Fay from the University of Kansas Medical Center. I just I want to make a comment and have y'all respond to that. It seems to me that you only have an emphasis. You can only allow a strict emphasis on adherence to RCT methods and the manual used in RCTs if you define evidence-based practice as only by looking at external evidence. If you're going to use the other two parts of evidence-based practice, which is concern for the professional's interest and expertise and the client's interest and expertise, then it seems to me that we're bound to look for ways to adapt the interventions. We can't not do that, or we're not doing our job. And in Lori's case, the work that they've done to try to identify what really are the active ingredients of that intervention and what could be left out or supplied in some other way is really something that needs to be done in every area. Thanks.
Well, I think we have a theme running through a lot of these questions and our presentations as well. And it is, if I may attempt a little bit of deconstruction or reframing or parsing of the earlier question on bridging the research to the evaluation in the field. It seems to me that NIH has given us a real opportunity to turn what they had not paid much attention to because they were so preoccupied with randomized controlled efficacy trials. They've given us a real opportunity to push this envelope toward a science of implementation. And so we have signaled, I think, with these presentations, the sentiment of a number of people who have been engaged in that enterprise that we can't continue to play by NIH rules alone as they have grown up through the peer review system. And so what we need to turn to, and what we increasingly find ourselves turning to, are other agencies of the government that have a stake in the implementation, like CDC, HRSA, CMS with its PCORI grants, EPA, the Department of Agriculture. All of them are delivery agencies who have a much greater stake than NIH in what happens when they turn the evidence loose out there. And that's where I think we have the opportunity to evaluate programs as they're being implemented with a much greater sense of support from the agencies who have a stake in the programs. That's my sense of the bureaucratic world view of this from a federal stance.
Well, is this still on? I don't know. Okay, so this would make it. stereo. So that's good. So I think going back to the question, the other thing, it's not necessarily the case that an adaptation must be necessary in order to think about some of these other domains. Certainly I do sit from the vantage point of the broader area of health services research in mental health, and the recognition that if nobody's going to come to the place where the service is being delivered, doesn't matter what it looks like, it's just not going to be received. If you can't work on access, if you can't work on a better organization of services, so it's not only that one says we have this intervention and there's no hope of it fitting anywhere without us thinking about adaptation. In fact, I think there are a lot of cases where there are other ways in which we can try and improve that fit. I think I specified what I saw as often being missed from that piece. I think there were more often cases where someone said, well, if that treatment isn't being received, it's probably the problem of that person who's just not showing up to get it, and trying to think about there are other targets that may themselves require certain adaptation or rethinking. But I think it is important not to say, and I don't think any of these presentations are doing so, not to say that we should now discount the good evidence that has come from different interventions, just to understand the nuance. And if we're thinking about fit, then we do at times need to be thinking about adaptation, or at least we need to be asking the question, is this able to be delivered as it was designed, rather than just saying it will be, and if that doesn't happen, it's someone else's problem, which is the way that not people in this room, but others have at times thought about this.
I'm Tom Campbell from the University of Texas, Dallas. My question is just a little different than the topic here today. We have a number of young faculty and a number of graduate students that are here today, and I'm sure they're all excited about the idea of doing this kind of research. So I guess, each one of you come from an academic background in an academic department. So I guess my question is it even advisable? I mean, my question is about who should be doing this implementation research. And is it even advisable for us to have young researchers starting their academic careers, even doing this side of the ledger as you start your own academic programs? So I was wondering about your collective wisdom academically on this.
My answer, and others may differ, but my answer is absolutely, of course. We actually do have a number of earlier career investigators who have absolutely said, this is exactly where I want to go, and they're being successful in getting there. So we do have, and I asked, I think at some point you'll get, hopefully everyone will get the latest announcement, but every year NIH with the VA has a training institute, which Jacob was in, for dissemination, implementation, research, and health. And the idea from NIH and the VA's perspective is absolutely that we need cohorts of investigators who are taking on these challenges. Enola has the NIMH-funded Implementation Research Institute, which is also a summer training institute specifically for mental health and now substance abuse. Ross Brownson now has the MT-DIRC. I think that's right, MT? Dissemination, implementation, research, and cancer. Right. Yeah. So that's for cancer is similar. So I think we feel that we need to build capacity, that those folks are getting through. For NIH, the problem is how large is the denominator of applications that are coming in? Right. Because there have been relatively consistent numerators in terms of what's being funded relative to that denominator. And so it is the case that the more people who are entering this field, the more at least we see being able to support more and more work in this field. But others may want to chime in.
Yeah, and just from my perspective, so in my department, which is a very basic science, Department of Psychiatry, they don't really get what I do. So the support for community engagement and those sorts of things is not very readily available. But I've been contacted by a number, and I'm actually a primary sponsor and or mentor on a number of career development awards. I've got an internal medicine doc at Hopkins who's getting into implementation science, somebody at Penn, different places in the country. And now what I'm seeing in our joint doctoral program in clinical psychology, more applicants asking for implementation science mentoring and training. So we're starting to see the kind of groundswell.
And of course, I echo that. I do training, but I also want to add some cautionary notes. As Greg said, a lot of academic environments, a lot of professions don't get it. I'm really privileged to work at a basically T1 university. Washington University has genomic strength. It's only recently developed strength in comparative effectiveness. So like I'm the outlier when you look across campus, but our CTSA director was bold enough to have a core in the, do you know what those are? The Institute for Clinical Translational Sciences. They're given to medical schools. I hope some of you were involved. So we have a core in implementation and dissemination research. Now, we look a lot different than the mouse core or the genome core. You know, it's like, what do I offer? You know, I don't offer slices of tissue. We offer expertise in this long road of developing research skills in a new arena. I'm the mother of two young adults who are finishing their dissertations and looking for jobs, not in science, but in the humanities where it's tough. And I'm a very invested chair of doctoral students, and I care about getting a job. So I know that young investigators are wondering, can I get a job? And I've seen in social work tremendous variability. I have a doctoral student who declares him or herself as an implementation researcher, and the job market, some people say, great, and other people say, what are you talking about? So my caution is to present and build a research agenda that encompasses health services research, that pitches implementation research not as the end, but as the means. The means for delivering better services. And then there are tenure and promotion requirements. And so many of the challenges that we know academic departments face with CBPR, with community-based research, also confront implementation researchers. So, you know, how I put all that together is to say, you know, for me it's the most meaningful work because it's work that is really focused on impact. But I recognize the challenges, and therefore I think you have to be extremely well trained. You need partnerships. If they're not at your own university, find them across a distance. And build collaboration teams that will let you have the support, the intellectual stimulation, and the toolkit to let you succeed in this. So I would say it's not for the faint of heart, but it's the best ride in town that I know of.
I want to take some exception to the assumption that we're all just academics. David currently and I in the past have been federal employees. I've worked for state and local health departments. I've worked internationally in the field, and I pride myself in a revolving door career in and out of academia, and I think it's informed my academic research. And it's a model of professionalism that I am encouraging academic doctoral students and postdocs to consider for their future, because I think the model we've had of people in health professional schools trying to be strictly academic is not serving us so well. I'm encouraging students to look for the opportunity to use the IPA mechanism for a year in a practice-based agency whenever they can.
I just want to make a quick comment in response to Tom. I would argue, so our probably you may not be aware, but our discipline, the departments are situated in different places. Some are in colleges of education, some are in colleges of arts and sciences, some are in medical schools, some are in allied health, and there may be some others as well. And I would argue that if somebody wants to do this kind of research, I would really urge them to get to a university that has a CTSA, maybe a medically or allied health kind of a department. I think if a young person were launching their career and they were in a college of arts and sciences or a college of education, I think it'd be very, very difficult for them to have the infrastructure and contacts that they would need. So I would argue, if this is someone's passion, yeah, absolutely nurture it in the way that you're talking about. But then I would say, if I had a student who was interested in this, I would totally guide them towards particularly a CTSA type of a place, environment, because you need that kind of an environment. This is not easy research to conduct. That's one thing you take away from this conference.
Yeah. So I think my response to that is pick your CTSA carefully. Because there are many that have no inkling of this type of work, and I think Enola alluded to that. And so I think the department matters less, or the type of department, than who is either in the department or ancillary to the department that you can connect with.
And I also want to pitch, I haven't been in touch with her recently, but I know Jean Century does implementation research in education. She's at University of Chicago and has a group, I think it's called Research Without Walls. But if you search Jean Century, century is in 100, she is pioneering implementation research in education. So recognizing the variety of settings, the variety of academic departments, and David and I have had an interesting year visiting several groups from cancer, HIV, now speech and hearing, autism. There are a variety of fields where this is taking off.
Yeah. And I would say, I don't know if the IES portfolio is searchable, but the NIH portfolio, you can go through and look for keywords: implementation, dissemination. So, I work with a couple folks that get IES funding here at UCSD, and also Aaron Lyon up at University of Washington, and other folks up there. So there are people out there doing it. We just need to kind of root them out and figure out how we can partner. Institute for Educational Science, right? Yeah.
There's also EIS, Epidemiology Intelligence trainees at CDC, and that's a career path unto itself, focused on this kind of research.
So whatever permutation of those 3 letters.
So my question is sort of a comment and a question. I would argue that we should encourage our students to do this. Absolutely. I mean, come on. That's why I invited you all here. So you got to do this. Yeah. But what I really enjoyed thinking about today was the importance of thinking about adaptability and sustainability, but thinking about how our research, not all of us are where Lori is. We want to be there. We want to be there and Barry guitar, and you're going to hear about these. But many of us are early in our, okay, I know I'm not real early in my research, but we're still early in our research. We're developing it. We may be doing the early implementation study. We may be moving from efficacy, like I'm doing, moving from efficacy into implementation. And what I'm excited about is thinking about how effectiveness really is the road to implementation, ultimate implementation, and that I can be adapting and learning about adaptation more positively versus, oh my gosh, adaptability, I need to have strict fidelity. No, I need to be incorporating into my treatment now thoughts about what implementation is. So, I think that's the real take-home message. Well, it is for me, and I'm going to tell my students, is you're doing your early studies. Think about implementation. Think about sustainability. How can you change them? How can you optimize what you're doing in these early stages? So I say absolutely, don't be afraid of it. Get into it. And you can still, as we talked about yesterday, there's a lot of single subject designs. There are a lot of small controlled studies that you could be doing, publishing, getting tenure, and moving on, I think, in an appropriate way. But your goal is still to implement. And so I do really have a question. after I gave that little speech, and that is, Larry, could you talk a little bit more about community-based as a source for looking at adaptability? So what I'm sort of struggling with is how you adapt and how you can utilize the information that you get from the community. And I know Kristen Centuria yesterday talked about, she's a medical anthropologist, and talked about the importance of the community in, and the stakeholders. We've talked about those today too. So do you have any guidance for that?
Well, I'm so sorry I missed that presentation because I neither want to repeat it or contradict it because I'm a big fan of community-based
You won't contradict.
participatory research. But I've dropped the term community-based in participatory research because there are so many opportunities for practitioners to be the participants with the researchers. And I think much of what we have focused on in these discussions has been just that, practitioner engaged research. But as we go to the community, I think we really have to look at the range of stakeholders for the issues that we're addressing. And in speech and hearing, the range of stakeholders is probably much broader than the usual clients. And engaging those stakeholders in helping us set the research agenda and priorities and decide what is the researchable object, that is the intervention, and how does it need to be adapted so that those stakeholders can collaborate in assuring its sustainability. Those are the kinds of issues that I think community brings into the formula for thinking about all of this. Thank you for the question.
Any other questions? Yes, please.
I want to just actually make a statement about the education and our students, whether or not we should be encouraging them. So I am someone who is trained speech therapist, and I went through the rehab science program at University of Washington and really turned my focus on health services. So when I went on the job market, the speech departments are like, yeah, you're kind of a little weird. You know, you don't fall into one of these nice little categories. You know, you do this health services, access to health care, but we're really looking for someone to teach our core classes, and this is not one of our core classes, so it's really interesting, but not quite sure where you fit in. So I really encourage, you know, I'm very excited about today and this conference about hopefully bringing this and expanding this type of research, but unless we allow a space for these types of researchers in our programs, in our faculty, then I'm going to be stuck in general internal medicine where I'm doing my research now. So.
Well, I think hopefully we're all the new messengers for this to get some change. So I can't thank you all enough for what you provided for our conference today. So thank you.